All right. We're all set to go. Thanks for joining me again, Andre. We're live here, or at least live tonight, the night before Bell Let's Talk Day, when you're joining me.
Hi.
So the countdown is on. Bell Let's Talk starts at 10:30 p.m. In Newfoundland. And of course, you write for a Bell-owned property, the Globe and Mail. What have you guys been doing, especially on the health beat, to cover mental health lately? Any stories that people might have heard of?
Well, we've been, first, just to correct, Bell doesn't own us anymore. They used to, but they got rid of that didn't really work out. Their whole convergence business didn't work out. So
this shows how up to date I am on the moving and shaking in the journalism world.
Nobody knows who owns media properties anymore. We're not sure, but owned by the lovely Thompson family, thankfully.
Okay, so I assume this was probably several years ago, and I just completely missed it.
Yeah, it wasn't that long ago, but the Thompsons owned it, sold a chunk to Bell, then bought it back. So
complicated. Well, in any event, you're still you're still one of the preeminent health journalists in Canada. I don't think many people would disagree with that. So tell me about the health-related stories you're working on outside of the Bell atmosphere that people might have recognized.
Yeah, so in the mental health field these days, I think we've been doing some work on psychiatrists and the lack of access to psychiatry. My colleague Aaron Anderson has been doing some wonderful pieces about that. We've been looking into this long-standing problem of not having access to psychologists. So there's a lot of attention being paid to. It's really hard to get help, especially for young people. And we know how important it is to get people treated quickly. If you let mental illness linger, it just gets worse. It gets harder to treat. So there's a lot of focus on that. Why aren't we doing more for young people? Because we know mental illness begins in a young age for most people. So why don't we nip this in the bud? Why don't we, all this prevention talk we talk about, why don't we apply that to mental health as well?
Yeah, so I want to pick up on a number of the points that you just made, but especially on the one around access to psychology. And I know Aaron Anderson, as you mentioned, has done some really in-depth, great work on this. But a lot of people don't realize that many Canadians sort of have universal access to psychiatry, and most antidepressants are prescribed by family docs anyway. But we know that psychotherapy, and that may or may not actually be delivered by a psychologist, but structured psychotherapy works just as well as many medications do, and often has longer term impacts. So if you're aware, I know this was more, Aaron's been delving into this quite a lot more, but has there been any progress in actually getting better access to publicly funded psychotherapy anywhere in Canada?
I'd say there's been baby steps. So Ontario stepped up the number of hours you can get for some people. A lot of private employers, most people depend on their private insurance for psychology. Right. It's very much like drugs in Canada. Drugs aren't covered for many people publicly, they're covered privately. Some private employers have stepped up because they're recognizing the importance of doing this. But there hasn't been a big movement. I think, to be fair, the fear of governments is that this will just, there's so much pent up demand. They're just afraid it will cost a lot. So that's troublesome, but it's understandable from a fiscal point of view, if not a policy point of view.
Right. Well, I think it's understandable from a short-term, 4-year increments kind of view, because really, if you invest in this now, it almost seems cliche to make this argument, but it's going to save a hell of a lot of money down the road in long-term disability.
Yeah, absolutely. We know that mental illness is the number one cause of short-term and long-term disability in Canada by far, but governments unfortunately don't tend to think long-term. They tend to think in the short term. I think the other thing to me that's really interesting about mental health is the history. Why do we have this quirkiness, right? And there's a very weird history that when we began Medicare, psychiatric hospitals were sort of carved off. They decided those aren't going to be covered. That's part of the penal system. It's not part of the health system. And I think this attitude sort of lingers to this day. Mental health is different. And as you and I have talked about on many occasions, we have to get over that, this artificial distinction between physical and mental health. They're connected. It's brain disease. We like to use the terminology brain disease now for that reason.
So this is something that I think the movement is necessary from, as they say in the UK, the perspective of parity of esteem.
Mhm.
But there are, I think, legitimate differences between mental illnesses and physical illnesses. While, of course, we know that the social determinants of health impact all aspects of our health, it seems particularly relevant when it comes to mental health problems and illnesses. Depression. There hasn't been a depression gene identified. There hasn't been one finite area of the brain implicated in depression. So it's also not quite the same. And I think that there's a danger in reducing the conversation of mental illness too far down into this idea of that it's a degenerative disease, because that can lead, I think, to really problematic places.
Yeah, sure, there are differences, but the point I just try to make when I talk to people about this is, imagine if we said we covered the liver, but we didn't cover the heart. It doesn't
Right.
make sense, and that's kind of the way we treat mental illness. But of course, there's many other social factors that come into play with mental illness the way they don't with other parts of the body, other organs, except maybe liver disease. We kind of be very assume that everybody has liver disease, drinks too much alcohol. So there are different
Right.
stigmas with different illnesses.
Absolutely. Now, you were heavily involved in the tainted blood scandal, of course. You reported on the AIDS crisis as well, I believe. We had talked
Yeah,
about it.
AIDS has sort of been the arc of my career. That's what I started with in the early 80s, and I'm still at it. Yeah.
Do you notice any commonalities between how we talk about mental health and mental illness? Maybe less so depression and anxiety, but more stigmatized illnesses like schizophrenia, for example, personality disorders, bipolar disorders. Is any of that reminiscent to how reticent people were to talk about AIDS at the time?
Yeah, it's funny. I was just having this conversation with a group of students recently because I've been at this about 40 years. I was telling them one of the things that always surprises me is how these same trends come around, the stigmatization, then sort of we have this awakening. Oh, I guess these people aren't so bad. And then we start dealing with them as normal. And I saw it with AIDS. I saw it with cancers. There was a time where nobody talked about their cancer because that was shameful. Then mental illness, we started talking more openly about it. Today, a really good example is transgender young people. Oh my God, we can't have that. We can't accept that. The way you're born is the way you are. And this sort of a lot of the language I hear is exactly what I heard people saying about AIDS, or what I heard about people saying with schizophrenia in the 90s. It all comes around. It's the same basic arguments. People are afraid, so then they put people in a box and say, "Oh, you're too scary. We can't do that." And then sort of realize, "Oh, well, my son or my neighbor's kid had that, so I guess it is normal people that are affected by whatever it is, whether it's AIDS or whether it's schizophrenia or whether it's being transgender." So I think when people get exposed to these issues and see people and conditions as a human reality, then we change our views. And I think that's why the media is important. Actually, we sort of normalize people for the public that's scared of things they don't understand.
Right. Now, it seems that Bell Let's Talk, more so than prior years. I mean, they've always shared personal stories in different ways or another, but that seems to be a real focus of the campaign this year. I've noticed a lot of their own talent, of course, but really sharing often intimate, unpolished, uncelebrity-like stories in a very unguarded way. And I think it does seem to be making a difference.
Yeah, and I think that's they're doing that in part because it's easier to do now. 20 years ago, it was really hard to get people to talk about mental illness openly. They were afraid of the feedback or the blowback they would get. That's become easier over the years because of media coverage, in part because of Bell Let's Talk. So there's just sort of a snowball effect. So now there's not near the stigma or the shame to talk about it.
Right.
But the argument I've always made, I'm a fan of Bell Let's Talk. I think they've contributed a lot of money. I think they've done a lot of good, just normalizing mental illness, saying, people with mental illness have illness like anyone else. The downside of it is I think there's a lot of hypocrisy where people support it, say this is great. But to me, when you tell people that it's okay to tell your story, that there shouldn't be stigma, I think there's an implied contract there that, hey, we're going to help you if you tell your story.
Right.
And I think we're failing on that part of it. So I think the initiative's great, but it's not good enough. It's leaving a lot of people hanging. So it sends a message, tell your story and we're going to love you.
Yeah.
We don't love you. We sort of just don't treat you. We
Or
forget to
something that I've noticed as well, tell your story, but not like that. Tell it the way that we want you to tell it, because it's more
Yeah,
cool.
tell it in a way that doesn't make us too uncomfortable, or we want it
Yeah,
to be a happy story. Every story has to have a happy ending, right? And a
right.
lot of mental illness stories don't have a happy ending, unfortunately.
No, they don't. Now, that said, I will say, part of the way I think that we break down stigma is sharing more of the stories of recovery. Because recovery, just speaking about the data, recovery is more common than it isn't. And whenever I say that, people never believe that. But the fact of the matter is that when people actually get the help they need, which is, of course, all too rare, but when they get the help they need, the help often works in the large majority of cases. And very often people just figure it out on their own. That's the worst way in the world to figure out, major depressive disorder is just slogging through it. But it does happen, and not all that uncommonly. Yet I think those are the stories that you don't really hear much of, are the messy ones. And that's partly what I've been trying to do with my podcast as well, is to show that there's lots of different routes to recovery, that recovery looks different for everybody. It's not always just take your meds and hallelujah, you're all better.
Yeah, and I think you're right. I think we in the mainstream media do a poor job of that, of covering recovery, other than black and white. And it's rarely black and white. Like, people get a little better, they have relapses, they get a little more better. And I think we pay far too much attention to sort of mild cases that do resolve on their own. And, I had depression and I got better magically. And I think that we need to focus a lot more attention on people with very severe mental illness. They're the ones that suffer the most, and it's a real tragedy. You look on our streets, you look at the number of homeless people. Almost all of them have severe mental illness, and it's untreated, and that makes us uncomfortable. Well, that's homelessness. That's not mental illness, right? And I
Yeah,
think we have to get into that messy stuff and recognize that some people don't get better, just like some people don't
yeah.
get better from cancer or heart disease.
So there's so much political stuff packed into a number of points that you just said.
You're welcome.
Oh yeah, no. But I think this is a tension that I often feel. That I think it's incredibly necessary to normalize discussions of mental health problems and illnesses. And one of my worries about only focusing on the 1%, or which in these terms are the most severe and persistent, often the people who are suffering the most, whose human rights are violated the most acutely, most routinely. That said, I think the counter argument to that is if you only focus on the most extreme cases, there's a risk that it could actually stigmatize mental illness more. Because depression, people don't know the difference. People don't have a lot of sensitivity and specificity between diagnoses. And you hear all the time, even in media, mental illness referred to in the singular. There's hundreds of diagnoses of different mental health problems and illnesses, depending on which manual you're using. So is somebody with social anxiety disorder or depression supposed to be as stigmatized as somebody who is homeless, potentially dealing with a substance use issue, potentially in prison because of the ways that the system failed them? I think that's. I'm rambling now, but this is my worry is that unless we better discriminate in a scientific sense, not in a bad sense, between illnesses, everybody just gets lumped into the same pot, and I'm not sure that's helpful.
Yeah, no, that's fair. And I'm not saying we should only focus on the severe mental illness, but I'm saying we shouldn't give them 1% of the coverage either. I think it's much more, needs a lot more attention because it's a lot more complex. And just somebody who's sad. I think too often we're pathologizing normal emotions. That's my worry, that some of our coverage goes that way. It's just like, I was sad, therefore I'm depressed. I'm nervous about my exam. That's not anxiety. And I think we harm people with mental illness when we do that, when we just take normal emotions and make them illnesses.
I think that's true. And I think that happens. That used to be the domain, I think, of medicine in some ways, that you'd have to worry about telling your doctor that you were sad because you would get diagnosed with depression. But now I think it's almost coming from the other direction, in that self-identify as having depression when it might be just sadness, and they don't know that, or chronic stress because they're going into a really stressful job and they're worried they're going to lose their job. Sure, that might result in an anxiety disorder, but that stressful situation itself isn't necessarily an anxiety disorder.
Yeah, we have to find the right balance there, and I don't think we've found it.
No, and this is where, and I'm going to let you go because I don't want to keep you all night, but this is where I think we still need to do more of the talk piece. Every single year, I've been active during the Bell Let's Talk campaigns for all 10 of the years so far, and it usually takes a grand total of about 15 minutes into the campaign before somebody says, "Bell, let's act. No more talk. Let's have action." We can all agree that we need more meaningful action on mental health in Canada. There's no question of that. But if we act without thinking, if we act without talking things through, and especially if we act without breaking down the stigma, then there is a chance that our actions might be stigmatizing, that they might not be the actions that people actually need and that are most evidence informed and helpful. So these are the types of things that I think we need to continue to talk about, are these types of issues that you've raised.
Yeah, fully agree. We need to keep talking, but not just talking. So there needs to be some talk. There needs to be some action. There needs to be more destigmatization. We have to just plug away at this stuff. But again, as I said, I'm a fan of Bell Let's Talk, and I just hope we can do more than that.
Yeah. Now, how can journalists, and we'll end on this one. I keep thinking of new things to ask you, but you were deeply involved, of course, in the journalism guidelines in Canada that provided recommendations for journalists on how to do that, how to talk in a better, more progressive, more sensitive and empathetic way. What are some recommendations you can give to people for how, the armchair journalist can do that too?
Yes, I think we've made big progress in the media with our language. People-centered language, I think, is really important. Recognition that these are illnesses, not moral failings. So a lot of this stuff has changed dramatically in the last few years, and that's great. I think it's important to talk to people with mental illness, not to just talk about them. That's sometimes hard, especially when you're writing about severe mental illness. It gets tricky, but I think we have to keep making those efforts. Patient-centered care is a hot topic these days, and I think it's more important in the mental health field than elsewhere, I think, because it's more about people. As you know, mental illness doesn't just affect a person, it affects their families, their workplace, their community. So it's a far-reaching illnesses that we talk about.
Yeah. Well, Andre Picard, health columnist for the non-Bell-owned Globe and Mail, the Thomson Reuters-owned Globe and Mail. Thank you so much for having this chat with me. We're gonna, I think, try to put it up tonight online, and then we're gonna play it throughout Bell Let's Talk Day tomorrow, since there are so many people having those kinds of conversations. Thank you so much for joining me.
Okay, always pleasure to chat, and do your exercises. Get the fingers limber for tweeting all day tomorrow.
Likewise. Thanks, Andre.
Okay, take care, Mark.
Bye-bye.